Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I'm pleased to welcome you to the multimedia summary for the journal's August 2023 issue. There are 3 articles that have been selected as our Editor's Choice or Highlights articles this month. Our Editor's Choice this month is a perspective and controversy article entitled Knowledge Management in an Academic Medical Center, Providing Clinical Knowledge at the Point of Care. It is authored by Dr. Rick Nishimura and colleagues from Mayo Clinic in Rochester, Minnesota. The current age of medical practice is privileged by the burgeoning of knowledge across the broad landscape of general medicine and its subspecialties, all of which have led to improved outcomes in patient care. This remarkable and encompassing advance, ironically, introduces its own unique challenge in that practice guidelines and standards of care now evolve relatively rapidly, thereby rendering more difficult the expeditious harnessing and discerning culling of relevant and up-to-date medical knowledge that, importantly, speaks directly to patient care. The Knowledge Management Program was developed at Mayo Clinic to assist the clinician in this regard. And in the current issue of Mayo Clinic Proceedings, Nishimura et al. Masterfully place in perspective the development, broad outlines, and contributions of the Knowledge Management Program. Mayo Clinic, an academic medical center that cohesively integrates large multi-specialty group practices, emphasizes teamwork, indeed one of Mayo Clinic's 8 value statements in the provision of patient care by its clinicians. Through its cornerstone program, the Ask Mayo Expert, the Knowledge Management Program enables physicians at Mayo Clinic to draw upon the expertise of their physician colleagues. Ask Mayo Expert is commonly used by the majority of Mayo Clinic clinicians. It provides succinct, Mayo-vetted knowledge bites on clinical issues and diseases that are epitomized by their ready applicability to patient management. It provides for the user information under the rubrics Clinical Answers, Guidelines and Resources, Patient Education, and Available Clinical Trials, and it affords access to experts for further consultation. A complementary product of the Knowledge Management Program is the Mayo Expert Decision Advisor, which integrates Mayo-vetted knowledge with patient data in the electronic health record, extracting and collating patient data relevant to the clinical issue and/or disease, and adding resources and tools that interpret and synthesize such information in the manner an expert clinician would. A salient intent of the Mayo Expert Decision Advisor is to mitigate the cognitive burden on clinicians and improve their efficiency in and their fulfillment with patient care. Dr. Samuel Johnson, the celebrated 18th century lexicographer and man of letters, wrote, "Knowledge is of 2 kinds. We know a subject ourselves, or we know where we can find information on it." We can add a third to Dr. Johnson's duo. We know how to glean, prioritize, and process relevant information. Mayo Clinic's The Knowledge Management Program exemplifies the third kind of knowledge as it applies to patient care. Dr. Nishimura and colleagues are to be warmly commended for highlighting these clinically innovative and vital knowledge management programs. Our first highlight article this month is a concise review entitled Primary Aldosteronism, a Pragmatic Approach to Diagnosis and Management. It is authored by Dr. Prerna Dogra and colleagues from Mayo Clinic in Rochester, Minnesota. The prevalence of hypertension in adults is now approaching 50% of the U.S. population, and as many as 20% of hypertensive adults may have underlying primary aldosteronism. Primary aldosteronism is typified by inappropriately increased renin-independent production of aldosterone, wherein renin levels are suppressed, and increased aldosterone production is generally driven either by an adrenal adenoma or bilateral adrenal hyperplasia. Compared with patients with essential hypertension, patients with primary aldosteronism are at an increased risk for cardiovascular diseases, renal disease, metabolic syndrome, and a diminished quality of life. In their review, Dogra et al. Emphasized the importance of excluding primary aldosteronism in patients with hypertension, as effective treatment of primary aldosteronism may obviate the need for or simplify antihypertensive therapy, as well as reduce the complications of primary aldosteronism. The authors address the application and interpretation of screening tests for primary aldosteronism, such as the plasma aldosterone to renin ratio. Attention is given to conditions under which this ratio is measured and to those antihypertensive therapies, such as drugs that interrupt the renin-angiotensin-aldosterone system, beta-adrenergic blockers, diuretics, and others that can influence this ratio. An important consideration is that these medications are more likely to cause a false negative test and quite unlikely to cause a false positive test. Screening begins with measuring the plasma aldosterone to renin ratio without first altering antihypertensive therapy. And if a negative result is obtained and the clinical suspicion exists that primary aldosteronism may be present, the authors suggest an approach of replacing the drugs that do affect the renin-angiotensin-aldosterone system with those that do not. Confirmatory tests that demonstrate the lack of suppressibility of aldosterone are discussed, and these include an oral salt load, intravenous saline, and administering captopril or fludrocortisone. Determining whether primary aldosteronism arises from an adrenal adenoma or bilateral adrenal hyperplasia proceeds with adrenal computed tomography and adrenal venous sampling. Unilateral laparoscopic adrenalectomy is the treatment of choice for a functional adrenal adenoma, and for patients in whom such surgical intervention is not feasible, or those with adrenal hyperplasia, medical management is indicated. The authors discuss the use of non-selective mineralocorticoid receptor antagonists, for example spironolactone, selective mineralocorticoid receptor antagonists, for example eplerenone, and the novel non-steroidal mineralocorticoid receptor antagonist finerenone. This outstanding concise review underscores the need to consider primary aldosteronism as a potential underlying cause for hypertension, clarifies and streamlines the needed diagnostic steps, highlights salient aspects of surgical and medical management, and concludes with a summary of the gratifying outcomes that can be achieved when primary aldosteronism is effectively treated. Our second highlight article is an original article entitled Subtypes of Type 2 Diabetes and Incident Cardiovascular Disease Risk, the UK Biobank and All of Us cohorts. It is authored by Dr. Chao-Chu Hsu from the School of Public Health and Tropical Medicine at Tulane University in New Orleans, Louisiana, and colleagues from the Harvard T.H. Chan School of Public Health, Boston, Massachusetts. Cardiovascular disease significantly contributes to morbidity and mortality in type 2 diabetes. Hsu et al. Question whether specific subtypes exist in type 2 diabetes and the extent to which these subtypes associate with the risk for incident cardiovascular disease. The analysis involved the UK Biobank and the All of Us research program. The UK Biobank is a prospective cohort of more than 500,000 participants in the United Kingdom that collected data pertaining to their health and disease and undertaken between 2006 and 2010. The All of Us cohort was initiated in 2018 in the United States with the intent to collect data on 1 million participants of diverse backgrounds regarding their health, disease, and genetics. Xu et al. Utilized a novel clustering algorithm that incorporated such variables as the age at which type 2 diabetes occur, BMI, hemoglobin A1C, and eGFR. Their results obtained from the UK Biobank and validated in the All of Us cohort reveal 5 phenotypically distinct subtypes: Cluster 1, early onset type 2 diabetes; Cluster 2, late onset type 2 diabetes; Cluster 3, type 2 diabetes with severe obesity; Cluster 4, type 2 diabetes with poor glycemic control; and Cluster 5, type 2 diabetes with poor kidney function. Associations with cardiovascular disease vary depending upon the specific cluster. Compared with Cluster 1, the risk for cardiovascular disease was highest for Cluster 5, poor renal function, followed by Cluster 4, poor glycemic control, and then Cluster 3, severe obesity, with such risks higher but not statistically so for Cluster 2, late onset type 2 diabetes. These findings underscore several considerations. First, chronic kidney disease is an independent risk factor for cardiovascular disease in general, and indeed is equivalent to other risk factors such as diabetes or prior myocardial infarction. The combination of both chronic kidney disease and type 2 diabetes thus synergize in driving the risk for cardiovascular disease in Cluster 5. The non-significant risk of cardiovascular disease in Clusters 1 and 2 may reflect the countervailing and offsetting effects of younger age, a protective effect, and duration of type 2 diabetes, an exacerbatory effect for cardiovascular disease. Finally, as pointed out by Xu et al., these findings are germane to the notion of precision prevention, wherein preventive approaches recognize the heterogeneity of phenotypes in type 2 diabetes. As for so many disease processes, type 2 diabetes, in its manifestations and complications, is characterized not by homogeneity, but by heterogeneity. You can access these highlights and editor's choice articles free of charge during the entire month of August. Please visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, where you'll find links to our social media by clicking the buttons at the bottom of the home page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights and our MCP 60 seconds video article synopses. Our website also includes our Mayo Clinic Proceedings issue summary and author highlight podcast recordings, which are available from our website on our homepage as well as through iTunes. You will also find our online-only feature and many news stories posted in the News from the Editor carousel on our website homepage that are based on articles published in Mayo Clinic Proceedings. And finally, you will see other free content as well as articles published online in press. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.